people want to glance through, kind of covers the ground that we covered last time through. And then if you have not signed the sign-in sheet, it was up here. I'll bring it, we'll pass it around at this time. Please do that. Okay, I've got it already. If you haven't, go ahead and take your name off there.
Yes, just started. Good or
just a heads up, we messed up our videotaping of the meeting last time because the place we borrowed the camera did not give us a video card or a memory card for the video. But we do have the memory card this time, so we are being recorded. Does anybody have any concern, question? We talked about this during our first meeting. The idea here is to enable people who aren't with us to be able to benefit from the process. Okay. I see very little response at all, so I'm going to assume that. Thank you very much, Karen. I saw a nod from Karen. I'm going to assume that means that Karen speaks for all of us that it's okay to videotape. Any trust?
Yes.
Joel and Sue are endorsing Karen's nod. That's good. Thank you. Maybe first just ask about the minutes. Did people have a chance to take a look through them? Any areas where we do have a correction on one spelling, which I took a note of? Any other items of interest or concern? I can give people a couple more minutes. We actually did a fair amount on July 10th, and that's why the meeting minutes are as likely as they are. I think we have italics where there were decision points in the meeting as well. Is that accurate? Statement, Michigan. So if you wanted to focus on italics too, though.
Is the flow chart reflective of the changes that were suggested?
No, the flow chart is reflective of the framework that existed at the time of the meeting, but we are going to have a component of this meeting that will review the changes made last time. So the narrative discusses the changes, and then we've got a revised flow chart to share with you today. That's a long-winded way of saying you're saying no. Not yet. Okay. Anybody have questions and or corrections to the minutes? Anybody want to move approval? Second. Joel and Sue?
Yep, you know.
Okay. Sue moves, Joel seconds. What I'd like to do is just kind of go over the agenda as we've constructed it. And this agenda has actually gone through some evolution over the last couple of weeks, in part because there's been, for those of you who may not be aware, I know some of you are, there was rather substantial effort put in by the data quality work group on looking at the data that is available for needs that have been identified from previous needs assessments. Some of which is based in significant quantitative information, as well as other portions of the data that we've got that are more of a perceived variety. Through that process, there's been, I think, discussions not only about data quality, but also the framework and ways in which we might kind of improve our overall process of dialogue. And some of that has been folded into the agenda as well. So let me review. Our hope today is I'd like to spend a few minutes going through the current framework as adjusted last time, which was the point I think that Sandy made at the outset. And then we'll turn to a report out from the data subcommittee. Dr. Baird is going to provide that. I think I saw her nominated at a meeting yesterday by the rest of the group.
Nominated and seconded.
This was not by fiat, this was by group consensus that Dr. Baird was going to present what that group has done. And they had a charge last time to look at the criteria that Dr. Baird shared with the group last week and come up with a way to look at weighting of that criteria and its application to health needs. And I would say that hey there, how's it going? Have a seat, Dan. From what I can gather, and I've looked at some of the outputs, they went well beyond, and they're going to share information not only on the criteria and the weighting, but how a lot of these indicators came out of that process. So very good progress was made there. There was also an effort, and I'm not sure if Josh and I debated as to whether to call this the data work group or just an ancillary effort. Josh, Phila, and Dr. Baird spent some time trying to condense these indicators. I don't know if you're aware, but these existing needs assessments that we have broke the world into some pretty fine slivers. And those fine slivers are intended to be indicators, but a lot of those indicators got at the same need concept. So Josh and Dr. Baird and others have kind of gone through a condensation process, so all of the indicator slivers are in now a common cup of needs, so to speak. So they're going to walk through what they did to do that, or actually Josh will, and then how the numbers came up in terms of numbers of needs we would be dealing with in that setting. In addition, we had a meeting last week with the health commissioners, as well as some follow-up discussions that came out of the data work groups. I guess first meeting, I understand, with Dunkin' Donuts. Was the second one at Dunkin' Donuts too?
We like that.
They like Dunkin' Donuts, so they had 2 meetings at Dunkin' Donuts, and then they did come, because I heard little fragments of various kinds at these meetings. At my request, I asked that we meet someplace where I could hear very directly kind of what some of their discussions had consisted of, and they came up with some ideas on the framework that I think are worthy of discussion in this group. So we hope to spend some time talking about those ideas. I think 2 key concepts there are the concept of prioritization, as well as any differences between the data-driven needs that we talked about 2 weeks ago and the perceptual needs, which we also talked about 2 weeks ago. So we want to spend some time talking about and then making any revisions this group thinks are appropriate to the framework as you move forward there. We closed the meeting, at least as I had envisioned it, looking at perceived needs. You all submitted a number of needs after our first homework assignment. We had good participation in that effort, about 15 sets of suggestions. We want to talk about whether the list of needs that we have now is complete in terms of your all's judgments, and have a dialogue about how any additional needs that you feel maybe should be on the list that aren't on the list can be folded in and dealt with however the group chooses to deal with those things. We'll close with a discussion on kind of how we get from here to there. Our objective here is a child report that will be informative in terms of enabling a common understanding of health needs in the county, and that will also provide a foundation for the health departments to move forward with some of the requirements that they have in place. And so that'll be the next steps to close the meeting, essentially. So that's the agenda that we put together. In part of this is predicated on what was expected when we closed our meeting last 2 weeks ago, and part of this builds on, I think, some good dialogue that's occurred since then. So that's what I had envisioned doing. I'm going to stop there. Does this make sense? Are there pieces that are missing? What do we need to change, if anything, about how we spend the next up to hour and 50 minutes or hour and 47 minutes? Okay. Okay. I'm going to hand out the or Josh is going to hand out the document. I have one copy. Sandy mentioned at the outset, appropriately so, that we did make some changes in the framework that was offered at the last meeting of this group. Circulate those around. And so what you have in your minutes from last week is the framework as it was presented to the group. What we're handing out now is the framework as it was adjusted, as we understand it last week. And I want to walk through kind of where this group is right now as we understand it. And this framework, by the way, should be consistent with the minutes, the narrative in the minutes that you all just reviewed. But it does visually capture several key changes that the group made and agreed to last week, at least according to our notes and recollections. Everybody have anything?
No, you have it.
I'm going to start on the front page, page 1 at the bottom, and point out that we used to have 3 green boxes in this framework, and we now only have 1 green box in this framework. And that green box is D1A, which is a substantiated health need driven by quality data. Well, what has happened since July 10 is there's been a fair amount of work to try to figure out, you know, which needs for which indicators exist that we have data made it to this driven by quality data box. Last meeting, there was discussion that essentially suggested that a substantiated need that is supported by quality data should not be viewed the same as a substantiated need that is driven more by perception. In other words, has not been through a data quality filter. So what we have now is 2 purple boxes at the bottom of this diagram that suggest that the evidence substantiating a need in those boxes is indeed not the same as a substantiated need that's driven by data that are determined to be quality. Now, the process for determining, for those of you who may not have been here 2 weeks ago, the process for determining whether there is sufficient data quality to support a need being placed in the green box involves identifying needs coming out of the 3 previous needs assessments that have come through. I see you looking, Heather, but jump in and correct me wherever I need to, because I'll acknowledge this framework, Heather was instrumental in helping us pull together. And one of the pieces we looked at was a benchmark for determining, you know, whether a need is better or worse than a Healthy People 2020 standard. If the data we've got indicate that the situation here in Portage County is worse than the Healthy People 2020 standard, then the next question to be addressed is, are the data that we're looking at data that we can believe? And when the data quality work group broke out last time, their charge was to sort out how we deal with that box D. And they indeed did do that, and they're going to be sharing some results on how those needs came out. If the data are determined to be of a high quality, and they are suggesting that Portage is worse than the Healthy People 2020 goal, then there you have a substantiated, data-driven need. And what you all said 2 weeks ago was, that's a different kind of need than a perceived need. And this chart now reflects that distinction more clearly as per your suggestion from July 10th. The other thing I'm going to point out, if you look in your minutes, there was an orange box in the area that is now F1A. There is no orange box anymore. And the reason for that is because we had a dialogue on July 10th that essentially asked the question, if the data we've got is determined to be high quality and it's not worse than the 2020 goal, should we just assume we're fine on that particular need or not? And this group, based on that dialogue, said, no, we want to look at it. There may be cases where this group suggested they want to do better than what the 2020 goal suggests. And so we have now changed that orange box to a perceived need kind of situation. Now, we'll have to figure out how to handle that scenario in terms of the analytics as we go through the process. But this diagram does reflect that this group felt that they wanted to take another look, even if the existing data is determined to be of good quality and it is indicating that Portage County is better off than the 2020 goal. That's still in the universe for dialogue based on the discussion that took place two weeks ago. Is that clear to people? I know there's some people who are here and some were not, so I'm trying to semi-review the overall framework as I go through and look at the changes. So that's the second significant change between what you looked at on July 10th and what you're looking at now on July 24th. I'm going to ask you to turn the framework over and look at the big purple box. When we talked last time we met on July 10th, this purple box consisted of a series of options. There were 4 of them at that time. And the discussion that ensued suggested that the first 2 options, which were rather lenient, they basically said, if somebody, one of the most lenient said, if somebody in this group thinks it's a need, well then it should be dealt with as a perceived need. I think the group rather strongly and unanimously said, just one of this group saying it's a need is not enough. There needs to be some greater substantiation. And after some dialogue, 2 things were suggested. That the 3rd and 4th options in the list that we provided in the original dialogue, and if you want to see those options, look in your minutes. But we didn't do the back page of the minutes.
They're in there. They're not in the diagram itself.
We came to essentially looking at the more stringent sets of evidence to support the idea that there's a perceived need that exists outside the realm of these data that make it through the full holy grail of data quality, so to speak. And so what you end up with here are what criteria we've now labeled 1 and 2. Before you jump into this too far, I will say there was dialogue about option 3 at that time and a desire generally to strengthen option 3. So the language in front of you represents our effort to strengthen the language in option 3 to reflect a higher burden of evidence, that there would be 2 outside sources supporting a testimonial from this group in some fashion before there would be recognition that it is a need worthy of having evidence in this perceptual category. So this box 2 has been altered, not as a series of options, but as the proposal that came out of the July 10th meeting last time. So this is our interpretation of the judgments that were made on July 10th. I'm going to stop now and essentially point out again, just by way of repetition, there are 3 major adjustments that were made. One is the differentiation between the Holy Grail data in the green box and all the other boxes, which is highlighted to a greater degree than it was in the draft you reviewed on July 10. The second is the orange is gone and is now replaced by a perceived bubble in bubble F1A. And that means that you all want to look at cases where Portage is doing better than the goal outlined in the Healthy People 2020. And then on the back box, there is a set of 2 items that might guide the substantiation of a need that is perceived. And by definition, that is a need for which there are not data that meet the Holy Grail that the data subcommittee had worked through the details of over the last 2 weeks. Does that sound like an accurate portrayal of what we did 2 weeks ago?
I have a point of clarification because I'm just confused by number 1 in the purple box.
Okay.
My notes say that we talked about the testimonial having to come from more than 1 member of the partnership, not that the more than 1 was from the supporting evidence. So I don't know if it matters necessarily, but that was what my recollection and what my notes were, that not just 1 member can say it, but if 2 people say that they feel that this is a strong need, and then you can have supporting evidence. That
Your recall, Sandy, matches Kelly. Others recall it the way, because we can make that adjustment. That was different than my recollection, but how does the group feel about that? So we would make,
I think it is.
I'm sorry, go ahead, Dan.
No, I think that's what we talked about.
Okay. So what we would, I'm gonna get the language down this time, Kelly, in terms of my notes. Testimonial from at least 2 members.
Yeah,
You
Of
just
the
say
partners.
testimonial from 2 or more.
yeah, 2 or more members of the
Okay.
partnership.
2 or more.
Right.
Okay. Members of the partnership with outside support from at least 1, I think was the language. So you're saying that language did not change in your mind, Kelly?
Right, it just needs to be switched, I think, the
Okay.
numbers are just
Okay.
switched.
People are comfortable with that, I've switched them on my notations, and we can make that change. Got that one? Any other questions? Other than that, did we accurately capture what the discussion was? Okay. So that's kind of where we are at the moment. Given that, what I'd like to do is turn the floor over to Dr. Baird, who, working with a number of folks in this room, spent a fair amount of time over the last 2 weeks.
5.5 hours.
That's
Not
just the
counting,
meeting
not
part.
counting Heather's time.
That's just the meeting part.
Yeah, not counting Heather's time.
Right.
Part of that, we were eating donuts.
Did you drink a coffee?
So I'm gonna turn we're passing out your handouts, Heather.
I'm
so
sorry?
We'll just turn the floor over to you to report on the work of the Data Quality Committee in terms of its charge of looking at the criteria you had shared, the weighting process, and their application.
So first off, I'm just the spokesperson, so if anybody that was involved in the data work group wants to chime in, please do so.
Okay.
They chose me as the spokesperson.
You bet.
So, second, I want to thank those of you who were able to come and participate in that 5.5 hours over 2 separate meetings very much, because again, if I was set to do this by myself, it would have just been the world according to Heather, and I don't think that would have benefited anyone. So it was very important, I think, for us to come up with a consensus, especially because I am absolutely not an expert in certain areas. So it was really good to have the outside expertise. So the data work group decided that they wanted to give you just kind of an overview of our process. So our purpose was to assess the data quality of 108 data indicators that came to us from the 3 separate community health assessments that we're dealing with. And ultimately, we wanted to be able to decide which indicators met some determined standard for data quality and which ones didn't. So we had a couple of tasks that we had to complete. You can see that there under the objectives. First, we had to determine a scoring mechanism for the 5 criteria that you guys approved. Then we had to actually go through and score each of the 108 indicators according to that mechanism for the 5 criteria. At which point, we took a break for a couple days, and I went home and played around with kind of different algorithms for combining those scores into one combined score. And I brought that information back to the group, in which case they actually looked through the different algorithms to decide which one they liked the best to create a combined score of data quality, and where we were going to place our cut point for what was considered the standard for quality data.
I'm not sure how the heck did you get 5.5 hours in?
Oh my gosh.
You wanna see our
That was the
spreadsheets?
meeting time.
Yeah, let's show this spreadsheet facetious, as you can.
They pass them down.
It's really loud. Watch yourself on this one.
You'll be buying the donuts next time.
No, well, they can sit through the process next time, I know that'll kill them.
That's why he's sitting by the doors.
No, I think it's outstanding work, I was just being smart.
So if you remember, the 5 criteria that we decided on at our last meeting were timeliness, in which case we considered not only how old the data was, but with regard to whether or not we thought the measure would change today as opposed to when it was last measured. We looked at representativeness and generalizability, and you should maybe have a sheet of kind of definitions that we looked at last time, if you still have that. Representativeness and generalizability, we considered how well that particular indicator captured the true health need, and also how well the population that was measured actually represented the population of need in Portage County. We looked at validity, so certain sources of data can have certain types of error associated, and we considered that with regard to some types of data. Statistical confidence, if the data were performed on a sample, perhaps we might have some confidence limits with regard to what the estimate is. And then we also considered consistency. Prior to the meeting, I went through all 108 indicators and tried to match up to Healthy People 2020 goals and targets. And I recorded those, and so I took with me information whether or not that particular indicator had a similar Healthy People 2020 target or one that was measured almost exact. And then I also looked to see which of these indicators were used in creating the county rankings and county health rankings. So not just any data indicator that's available on that website, but that actually is a part of that overall ranking score. And then we considered if they were a part of one or both of those, that they were used consistently in nationwide projects to inform public health. But then we also considered, potential areas where, data might inform public health at the local level or at the state level. And so, in a lot of ways, the data work group knew more about that stuff and helped to facilitate that process. So the ultimate scoring mechanism that we came up with was the same as what was in the example, the 0, 1, or 2 points for each of the criteria. However, before I had 0 as poor, we decided that 0 would be considered fair, and that all of these were measured in some way from usually pretty well-known data sources, that really there's nothing poor. Some of them have, less applicability to those particular criteria than others. So we decided the lowest end would be fair, 1 point for good, and 2 points for very good. And so once we actually went through and scored those 5 criteria on every single indicator, which actually I don't think took all that long. We did okay.
3 hours. Depends on what, you consider that long or not.
I actually took that information back and played with it. I probably tried out maybe 10 to 12 different algorithms or ways to combine those 5 scores into something that I thought maybe would be meaningful to bring forth to the group. And I should say, before that, in our initial meeting, they did tell me that they thought that representativeness and generalizability and validity were much more important than the other 3 criteria. So in my mind, we kind of discussed, or I thought about different ways we could weight it. We discussed different ways we could weight that, maybe making those criteria worth double the amount of the other criteria, just as ideas. So I played around with different ways of combining those scores into simple weighting algorithms. So I brought what I thought were the 5 most feasible algorithms. Believe it or not, I played with like 10 or 12, and most of them performed really similar. I left in the most extreme case or I guess the most conservative case and the most liberal case, and then some of those that were in between. And we actually went through and looked at, well, if we use this algorithm, what would happen to certain indicators? And the data work group decided on a particular algorithm that they liked the best with regard to which indicators met the standard for data quality and which indicators didn't. And that happened to be an algorithm where it was decided that the indicator had to have scored at least a 1 or a 2, so good or better, in validity, representativeness, and generalizability. So it had to score, it basically couldn't score a 0 there. Couldn't be fair or worse. In which case then it would automatically be given a combined score of 0. And then the additive score was simply the addition of all of the points for the 5 criteria. And we looked then at the distribution and of those additive points, and there was a pretty clear cut point, we felt, which happened to be 7. So we considered anything with 7 out of 10 points to be the standard for a data set of quality, that met the standard of quality. Anything less than that did not meet the standard. So our results were that we ended up with 22 indicators where the combined score ended up being 0 because it did not meet that criteria of representativeness, generalizability, and validity. And then 13 indicators did not meet the standard of quality because they had a total combined score of 6 or less. And then we had 73 of the indicators that actually met our data quality standard with a score of at least 7 out of 10 and at least good or better in representativeness, generalizability, and validity. So if you actually take a look at this particular sheet that was passed out, you can see here the data indicators, so all 108 should be represented here with the data source, the year, and the total combined score that we decided according to the algorithm that was chosen, and whether or not that particular indicator meets the standard for data quality. And I would like to open it up that, as you're going through this, it doesn't even have to be right now. If you have any questions with regard to how these particular things were scored, anyone in the data work group would be more than willing to share the results with you and discuss why they decided as a consensus to score those particular indicators in those ways. So this is the result of the data work group, 5.5 hours.
Of our time, much more of yours.
And then one additional thing that we did is that some of the indicators in here were duplicates. And they were duplicates because they either came from different data sources or they came from different years, and therefore oftentimes produced different results. And so in that instance, we had a problem with which one do we use and which one do we believe. And it's kind of redundant to put both of them in there. And so it was decided to use this data quality score to remove duplicate indicators. So you can see here on the first page, there are 2 indicators that are the percent of children 19 years of age and younger enrolled in Medicaid. One was measured in 2007, the other one was measured in 2009. In this particular instance, they ended up with the same combined score, so we decided to keep the one that was later. When you look at the percent of the population enrolled in Medicaid, 2 indicators down, the one below it actually scored higher on the quality scale, an 8 out of 10, as opposed to the one above, which scored 7 out of 10. So we kept the one with the 8 out of 10. And so that happened, I believe, for, Josh, you counted them, it was 8 indicators? For 8 indicators. So that way we knew which result then to apply to the Healthy People 2020 target. Because if we were sitting with 2 separate results, we weren't sure which one to apply. And so that's what we did. Did I miss anything?
No, you did great. I think one of the things to remind people, this is the data driven indicators. This is just one portion, so any of the perceived are not really represented in here at all. So we're not talking about perceived, oh, I think this is not important. We're only talking about data.
From the 3 health assessments.
From the health assessments.
From the
So
3 health
we're only
assessments.
talking about this process.
That's only that
Yeah.
column right there.
And just to reiterate, it's probably been a month now since we discussed. These are the 108 data indicators that those 3 health assessments thought were priorities. Okay, so we're already kind of dealing with a set of priority data indicators. So we're just looking at, with this particular process, deciding whether or not we want to believe the results based on a standard of data quality.
My only question, this is a very good job, I really appreciate the process. Where did the number 7 come as the cutoff? I'm just curious.
Just actually pretty
It's
simple.
a
There was
C.
there was no
Low C.
mathematics to it. It was just eyeballing it. All of the indicators seem to, or combined scores seem to perform in a way where, there was just a total drop in the number of indicators that had that number. And it seemed to be a pretty clear point where we could cut the standard. And then another way that we validated that went through the scores for that particular algorithm and looked at, okay, well, if we change that then to a 6, which indicators would we be adding in, and do we think that it would be, pertinent to do that?
If you look through here, there's so few 6s. Everything else drops pretty fast.
Yeah, it did. I mean, and almost every single one of the algorithms, the distribution just fell off.
I think we have to be cognizant too that the list has to be managed.
With the criteria the quality indicator, that we suspect will have changed significantly, like the percent of people with insurance will have changed significantly because of the Affordable Care Act, so how do you?
We scored that, almost all of those as a 0 with timeliness because of the change in the environment.
Timeliness.
On just that one measure. So they may have scored okay overall because of the rest of the measures, but they were still poor for timeliness.
Because there's no data right now. I mean, technically on some indicators, there just isn't. So it's not that they're thrown out, it's just they're not on the data set unless they've got the other indicators.
But it's a 7, so what am I missing?
The zeros, are you wondering why that's not a 0? It became a 7, because the only ones we kicked out with a 0 were the ones that were generalizability, reliability, and validity. If those had zeros, they were kicked out because we figured that if they weren't valid, then there was no point talking about them.
That was actually one of the algorithms that I put into place, was that if the indicator had a 0 in any of the criteria, then we kicked it out, and I think that kicked out and only left like 23 something.
Yeah.
So that was one of our most extreme cases.
Any other comments or questions on the data quality work groups efforts?
I was gonna say, just to reinforce what Sandy says, though, it's like with Medicaid data, it's like, the data there is valid at the time. We know today it's in flux at this point. It's totally changing just based on recent changes in the laws and so forth. So there's a new goal to keep achieving this.
So that was taken into account by giving the 0 and the timeliness, but it remained in because it was still reliable and still valid, but it wasn't necessarily timely. That's why it didn't get a 10, for instance.
Right, exactly.
And I think that's why you see some of these health insurance ones fell out and some of them didn't, because they were all right there on the cusp. They all 7s and 6s.
Any other question or comment here? Point of process on this. The data work group spent a lot of time sifting through a lot of information here, and they have come to a series of judgments. Dr. Baird, for those of you who were not participating in the data work group, extended an invitation to anybody in the room if they wonder or have questions about any particular indicator, to approach her or another person in the work group about that indicator.
And also about the alphabet soup that's on here too. Yeah. Just for the interest of space, government, we all like to make all of these alphabet soup. So if you want to know what is SAIPE, I'd be more than happy. It's really against my nature to just put that in there without having the explanation, but for the work group, we did that.
The question, I think, before the group is kind of how to address and follow up on what was a significant, and I must say I was on the periphery only of this effort, but I saw evidence of the work as it was ensuing. There was a significant effort put into this. The question I would ask the group is if they are comfortable as a whole with the results that have come out of this effort, and accept that as a way to look at the data-driven needs in the green box in the framework, particularly given the ability of anybody in this room to come back and revisit any particular indicator with the work group. So I would ask, given that, if people in the group as a whole are comfortable accepting this output of the data work group committee as the output of the larger partnership, with the idea that at our next meeting, we would revisit any issue that somebody wanted to raise after speaking with Dr. Baird or other members of the group about any particular indicator. I'm kind of asking a question. Are you willing to accept what we've got here with that qualification?
You want a motion?
What's that?
You want a motion?
That would be great.
I was on the data work group, so I'm not going to give a motion, but I'm.
Abstain, yes.
That's why half of us are sitting here, but.
So
Yeah.
moved.
I'll second that.
Okay, so we've got a motion from Commissioner Porter and a second from Mr. Mallory to accept the work of the work group here, pending follow-up discussions and a return to this point at our next meeting for dialogue that may occur between now and then.
I would like to add to accept with gratitude.
Very good. I'll do a round of applause on that. Thank you. There was a fair amount of work put into this. I could just see it, and there were emails flying, there were people coming back and forth in our little neck of the woods talking about pieces of this, and so I know there was a lot of effort, and thank you, Heather, and thank you, all of you on the work group for the work.
Couldn't have done it without Heather.
Yeah.
It's been awesome.
I couldn't have done it without coffee and donuts. No, actually, more than that, their help.
I'm just gonna ask, are people comfortable with the motion that Commissioner Porter and Mr. Mallory have made? Any discussion on that motion? If people wanna have any kind of vote or discussion, we can. If there is no desire for that, I would suggest that we could accept the group decision by consensus if you choose. Stop. See. We're good?
Good.
Okay, so what we'll do then is we'll proceed with the understanding that these results are what have come out of the data work group's efforts. But anybody in this group around the room or people who are absent today can look at these indicators. If they have question or concern, I would encourage you to approach a member of the data work group and get your questions resolved on any indicators. If there are any indicators that people, after having that consultation, have concern about, I would ask them to contact Josh, and we'll get a discussion on that at our next meeting. Okay?
I would add that, at least from my personal opinion, that you look past your personal goals and look at the big picture that we have out there. This is our first attempt, and while we know we have things out there that can't be addressed this time, there will be other community health assessments in the future, ongoing process, and I think we need to make an attempt to keep a workable list that we can actually have a goal of actually completing and doing some of these. When it comes to the improvement plan, can we pick some of these and actually do them? And the ones that are going to be the low-hanging fruit are going to be those that can be data supported or sustainable from other means. So just keep that in.
Any other discussion following Chip's comment? Okay. Concurrent, interwoven with the work of the data work group on its data quality charge were a number of other discussions occurring over the last 2 weeks. And I've asked Josh to present some information that also came out of efforts that he and Dr. Baird made since July 10th. One of the pieces of dialogue that I heard coming from people who were participating in the data work group, and indeed I think were even mentioned at our July 10 meeting, if I recall correctly, is the point that we have lots of indicators, but some of these indicators are really trying to get at the same kind of need. And following Chip's comment about trying to have a manageable number of needs to deal with, Josh and Heather put together an effort to essentially take the indicators that existed and collapse them into a set of needs. In addition, through that process, they looked at some of the needs that came out of the 3 needs assessments that were either very broad or not particularly well substantiated, and to edit those down in certain areas. So I'm going to turn the floor over to Josh to talk about that process.
All right, have a seat. This was a lot simpler than what the data work group did. Basically started with a list of 100 indicators, and we pretty much eyeballed them and tried to group the indicators that were trying to measure the same thing into categories. And those categories are the thing being measured, so those are the needs. And after we got all the indicators grouped, I took the list of needs that this group provided through your homework, and I added either they got absorbed into the needs that were already on the list, where there was some overlap, or they basically got added to this list. And the same goes for the perceived needs from the 3 assessments that were not based on data. So in the end, the 100 indicators were grouped into 80 separate needs. And based on the data work group's results, 12 of those needs are data supported. 1 has a conflict where the data is kind of going in 2 directions, and then 67 of those needs fall into the perceived needs category. So they're listed here. So the way to look at this, the terminology next to the numbers is the need, the sub-bullets are the indicators. So 12 are the data supported needs. The 1 need that is a conflict on page 2 is number 13. That's unhealthy weight of children. And the remaining 67 would fall into the perceived category.
On number 3 on the first page, I think the last bullet should be removed. So this got added in on accident. The percent of female Medicare enrollees, the data work group determined that one was not quality or did not meet the standard.
Right, this is just showing the grouping where they
Oh,
would
just the
fall under.
grouping.
This is
Because it
this
says
is-
quality data and worse the goals up above, so that's why I was.
The need itself ends up being quality because one of the indicators has quality data and meets the benchmark. The other indicators either weren't quality data or they did not have a benchmark.
So it remained a need because there's at least one.
Because the one indicator that's data we trust and has a benchmark says
Pushes it in.
Yeah.
Even if that's not the benchmark, we think they should be measured,
Well, it's healthy people 20.
even though we disagree with other people's what to be. Sorry. Good.
And at the bottom of this, I can give you all a minute to absorb this, but at the last page, there's a little table that shows where things kind of fell out. And so 39 total needs were determined to have quality data by the group. 33 did not have quality data, and 7 of the needs ended up having no data support in them. And the box in the upper left-hand corner with 12 needs and 20 indicators, the number in the parentheses are the indicators. That would be the green box. And that's those are the 12 that are data supported.
I'm a little bit concerned about number 1 and 2 being on there because of the rapid change in insurance status of the nation and in particular of our area. Even though, and the data sources are fairly old, and even if they were last year, they would be substantially different than what it will be even at this moment.
Chris, you mentioned that in the group of, what we did was timeliness was only one of the 5 measurements. And timeliness was the one that we got 0 in that, for that category. There were other things that they measured that were, we agreed, there's not a lot of pertinent data at this point, but that didn't throw out the indicator with the rest of the validity and all the other indicators. That's why we did it through an algorithm and not through personal. We threw out the timeliness and said, yeah, get a 0 in that, because we can't measure anything right now, because it just happened, it just started.
Well, actually, we can measure this now.
Okay.
We have very specific data on the number of people that have enrolled. So it is a very measurable, there is new data on this.
Yeah,
So,
I would agree with that. I'm concerned if we're drawing conclusions that this is a health need.
Exactly.
Maybe it's not at this point, this has been
Yeah.
resolved in the
These
last.
are then gonna go through a prioritization process in the CHIP.
right.
You know, so those are considerations that will be taken into account when that group decides how they're going to make planning efforts to combat these health needs.
So that may fall out then, it's no longer an issue because it became voluntary.
I'm gonna just interject and see if we can find a middle ground, because the point that is being made here is, nobody's disputing, from what I can gather, the reality that
Yes.
Dr. Drummond is pointing out, and Joel is observing as well, that there is a change in circumstances that's evident. The piece that strikes me as interesting here is Dr. Drummond pointing out that there are data that one might access. I mean, I have seen the newspaper estimates, I don't know about the Portage County estimates. But I would just suggest that the language of the report could recognize this changing reality as a part of the dialogue there in some way, shape, or form, and make the contextual point that I see being made. I think the other thing here has to do with the point that Heather has outlined, and that is, this is producing a set of needs based on a determined methodology. Those set of needs will be written into the report, but the overall language of the report can recognize contextual issues that, like those being raised, it strikes me, if the group is amenable to that. So I don't know.
And if
I don't know if that starts to craft a middle ground here or not.
And even from a data standpoint, it can be difficult to make some interpretations from that, because we do know how many people have enrolled, but we don't know then how many people are still uninsured. We just have a number of new enrollees, but they may have had insurance in some other fashion. So we can't just simply add those together and look at who was uninsured previously and add that number and say, well, they're newly insured because of some of the crossover. So it's still somewhat difficult for us to be able to say, you know, what is the burden of lack of insurance in our population right now.
So what is the academic standard and epidemiologic standard for the age of data? At what point is it no longer considered valid?
I think it really depends on the health issue that you're looking at.
Well, let's look
whether-
at insurance.
Insurance, I would say data from last year is not very timely, because there has been a change in the environment. Those external factors that we were talking about that make it that the estimate that we're given, the result that we're given, we expect it to be different now.
Can I
So-
also, sorry. Jim, you wanna, we were looking at this as data and what we had in front of us. And we did have a discussion about, you know, there's lots of changes. And so we determined that we didn't have it with us, because we zeroed out. But just because it fits in one category or another doesn't mean it's dead in the water because of the second process. But Chris, I do hear you, I know what you're saying, 'cause
Yeah.
we have the same thing, Medicaid the same way. We're just, what we had, we only scored it low in timeliness because we didn't have that information in front of us.
I just want the validity of this document, of our final assessment, for people not to be going, oh, they were using data from 2008, 6-year-old data, to make this assessment. It really reduces the impact of the document.
But
So that's my only.
there are instances where we determined that 2008 data is not bad. That we don't expect
Depending
that
on what it is.
measurement really to change that much since 2008, or it's something that is very slow to change. And so those estimates are still very useful.
I think that regardless of the numbers, it's a perceived need. You know, I think that's what has to be debunked when we get to the improvement plan, but it's still going to be a perceived need. I think in health insurance, we wouldn't have the Affordable Act if we didn't think health insurance was a problem.
And I think part of the frustration is there is no way of saying data is available for everything last year. So I think when we look at data, we have to make some decisions of what is or is not. If we just said that anything before 2010, we're not gonna use, we just lose a whole lot of needs, because there isn't data available for that. So I think at any time we look at data, you have to, one of the limitations of looking at data is that you may not have, you have to make these decisions.
Go ahead, Doctor, do you have,
We did have a census report in 2010 that did report on percent of single-parent households. So I'll just take the very first one. So, because we were looking at data from 05 and 07.
It depends on where that particular community health assessment got their data. The methodology for the CHA that included that particular indicator used results from the county health rankings and the community health status indicators, which reported the data from 2005 to 2007.
So we're not going to pull in more recent data when we have access to it.
We decided that we had to use what we have available in regards to reports already available in Portage County that are using certain data elements as a starting point, knowing that when we look at the community health improvement plan, we're gonna say these are gaps that we need to try to make sure that we're able to capture this data in a better frequency.
And the
Next
MCH
time.
assessment did use in indicators of the percent of female-headed households with children from a more recent ACS estimate. I think it was 2008 through 11. And it was determined through that particular assessment's prioritization process that that wasn't a priority.
and I'll just interject, because I think you're raising a point that is gonna come up later in our discussion as well, Dr. Drummond, and that is, as we proceed here, you know, there's a whole body of these perceived needs, and evidence supporting those perceived needs is expected, as I understand it, to be brought forward. So while the data what we're talking about now, I think, is the data quality work groups procedures. And I'm quite frankly interpreting your comments, and I think they're a valid line of questioning, obviously, at least that would be my interpretation, would be the kind of thing we may need to revisit at our next meeting. But I would also mention that there's opportunity, if the group wants to do this, to enter new data into the report over time as a part of the perceived needs process. And so for that reason, I don't think we need to say that if we've got more data on our fingertips, it can't go into the report. And that might provide an avenue to balance out the point here. So I don't know if that's responsive, because I think you're on the line of thinking, put it this way, if you don't raise this, somebody else is gonna raise this.
Right.
So it does need to be dealt with in some ways, right?
I agree. I really do think that our task was what was in front of us to determine. I think if we had more time, then maybe we could have somebody do more research on the data that could be collected. And I think that's very valid, very valid point. I do think, though, the good news is that we have a second part where somebody can bring in current data, and we can use that data in order to bump up any of these categories, whether they're considered not in the data center or the other. So that's where we were coming from. So yes, this is what we have.
What if we think
And to
of it this way?
clarify, I'm sorry, Dr. Maury.
I was just gonna say, what if we just think of it this way? I mean, that has always been a perceived need, or not perceived, it has been a need, at least through the end of November, December, about the lack of health insurance. So I guess I would keep it here for sure, because it shows up, it fits in with everything. But certainly, we want to know, has it improved? I think that we definitely want to look at that kind of thing. So I'd like to keep it as a need anyhow, but really get some more data.
The real
on it as
indicator
well.
that needs to be measured there is not whether you're carrying a card saying that you're insured, it's whether you're getting health care.
Right.
That's the indicator that needs to be measured. How many people that have insurance are actually accessing health care? Because I think the whole reason that you're assuming that it's a need because children under the age of 17 or 19 don't have health care, is that they're not going to get, if they don't have health insurance, they're not going to get health care. And that becomes a need because they're not entering into the system. But now that we have a process in the nation that can get more people covered, we still know as healthcare providers, that doesn't mean that people are going to actually get health care.
Well, and also depending on the plan they get, because some of them have $6,000 deductibles,
Right.
which is gonna prohibit them from getting care. So I can't pay $6,000.
I do wanna clarify with this too, just in case there's a misinterpretation. We are not in any way using our data quality results to invalidate a health need. All we are doing is using the data quality results to decide whether or not we believe the data that has been presented. And even if we don't believe the data that has been presented, it goes over into the perceived health needs box.
So this, we didn't believe this data probably because of what you're saying. The 2005 to 2007 is not good data. So because that has an X, we're saying that data was not good enough.
So that doesn't mean we're not saying that single parent households aren't important. We're just saying
We
this
need more
data
data.
isn't good enough for us to determine that. Therefore, let the partnership decide on it.
I think we're saying the same thing, that this 2005 to 2007 is not good enough.
Can I just interject by way of process? This is good dialogue. My sense is everybody recognized the world has changed in the manner that Dr. Drummond has articulated. I think the piece that may be new is she may be aware of some information that was not available to the group. I would ask if you can, I don't know if you can provide to us whatever data you've got. Why don't we look at that and then we can return to this discussion, much as we just agreed to do for any indicator that raises questions at our next meeting. And that way we can have a discussion after we've talked about the framework adjustments that are in front of us on the agenda. Is that okay with you?
Thank you. There would be Medicaid expansion data also, so there is good baseline data, penetration rates, and where Portage County sits right now, so that would be another example. But maybe we're just not done with the flow chart, so it seems like
We aren't.
what you've come up with is kind of our baseline. And so I hear you talking about prioritizations, and maybe eventually we just continue to develop our flow chart.
Yes.
Did I hear, Sandy, that you have at your fingertips information relevant to this question in addition to what Dr. Drummond was pointing towards?
Specific to medication expansion, there's reports by county that describe penetration rates pre-expansion and post.
Would you be willing to send that our way?
If I can get a current one, I will.
If you can't, don't worry about it. But one of the things we did say at the outset, this is the part of the first step in a much larger process that's going to occur over years. We want to take what we can get our hands on quickly and integrate it, and particularly on an important issue like this one. At the same time, there'll be multiple opportunities in the future in the CHIP and then in subsequent efforts to upgrade the data underlying the judgments. Josh, do you have further things you want to offer in terms of the grouping of indicators and the needs?
I would like to just quickly go over the second piece of paper that went around. There's drop perceived needs at the top. As I went through the grouping process, I identified some needs that came out of the previous assessments that were not backed by data. They came from interviews, basically, that were either, we felt, overly broad, or they weren't specific enough to health itself and maybe related to health departments. So for example, funding is on here, research / community level research showed up on the list, and we felt that those should be dropped out of the needs list that this group considers. That being said, any of these can be re-added. I just ask as we re-add it to think how we can narrow the focus down to something a little more focused.
Just by way of context, some of these suggestions were the loose ends, that in some cases, I'm familiar with a number of these, that came from single comments, from single individuals, very broadly construed a year and a half ago. So these were the loose ends on top of the quantitative information out of this particular needs assessment. judgment that Josh made going through here is, if we're gonna focus on something in this list, we ought to define our terms a little more clearly. So the question I would ask of the group is there concern about bouncing any of these out? And I will ask that question and then point out at a later point on our agenda, there is opportunity to add new perceived needs. So some subcategory of one of these could go on that list.
So is your question, John, that we're gonna go through and take every one of these through the next process in the purple box?
Yeah,
Was that what you're asking?
What we're doing is that we're taking this group out of that.
Okay.
That's the first question. Are people comfortable with that?
And why are we doing that? I'm
Yeah.
sorry.
If you look at the list, we have very broad things like sense of community is a health need. Healthcare delivery system. If you look at the concepts here, they're very broad, they're not specific enough. And that's the basis upon which Josh is suggesting that these would be candidates for removal to keep this a manageable.
I guess I'm getting stuck on immunization.
Yeah, me too, I'm stuck on that one.
All right, so,
Okay, that's what we need to surface at this
I mean,
point.
that's a health, I mean, that's not
If
broad.
it just said immunizations, what did it say? I guess,
Yeah, I guess that's.
you know,
what we're
percentage
here.
of children that are adequately immunized is a problem in Portage County.
Right.
So if it just wasn't worded accurately, then maybe we need to reword it, and it should fall under a maternal child health need as a broad category addressing health status of children.
That's what we wanted to hear.
Did the immunizations, I mean, my interpretation when I saw that was immunized for what and whom. And I'm not sure there was clarity, but given what you said, we just add it to the perceived needs list and it can proceed just as you suggested, Kelly.
Yeah, I think that one sticks out very different than the other ones on this one.
Okay. Are there any others that need to be, and I guess I would say that given what I understand to be the logic behind this, what we call the dumping list at one point or another earlier last week, we might encourage some more specificity behind this point, much like what Kelly just articulated.
Well, I have concerns, mine is the public education, and public awareness for public health. In the communities I deal with, those are very lacking. And I look at the powerful people around this table from the last meeting, you folks who are here, I wish you would come out to some of these communities that I deal with. You know, we need your programs here. I mean, we got viable community centers that don't have programs in it, that help, so awareness, you know, those are very important to us. So I hope that you consider public education, public awareness, public health.
But what exactly about if we could narrow the focus of that to more accurately define the need with regard to public education?
Well, it's on the basis of education. A lot of people, especially our elderly people in our community, aren't educated on the health needs. You know, they see certain things. Our children who could be really educating their families, if there were programs in the community and they were taking stuff home. A lot of us, how do we educate ourselves? My grandkids bring stuff home, throw it on the table. Guess what I do? I look at it. And parents have done that over the centuries. You know, we need to reevaluate how we're educating people in Portage County. We don't educate them the same way they do in Cotton County or Franklin County or somewhere else. We have a group of people who look at things differently. And I'm glad I'm sitting at the table to tell you this. Pardon me?
I guess what I'm asking is through the public school system?
No.
Public education.
Public education through
Just to
our
the public.
agencies
Educate
that
the
are
public.
here.
I don't know that that's what the person meant when they wrote that there.
Oh, that's him. He rose.
No, these all came from key stakeholder interviews when Dr. Hornbeek and his group.
These are my two. I'm here to talk about those two. I really support those two.
Your two that you did in your homework for this group?
This right here. Those two are very important to me.
I don't disagree with you that they're important, Frank. I'm not sure that they're a health need. So I think we need to differentiate between a health need and increasing awareness about health needs
Right.
as part of what we do in the improvement process. So
Like
improving the health of our community, one of our goals is going to be to increase public awareness and education about these needs that we are today and then through this process trying to establish. So one of the big components in the CHIP, the Community Health Improvement Plan, is public education and awareness.
And are we talking about specific programs like public awareness of diabetes care and public awareness of health needs like that? Is that what you're thinking?
Any program.
Right, and I think that's
Any
where
program.
we're getting stuck, is this is too general as opposed to specific programs like that. We need, I don't disagree, we need all sorts of health programs, but I heard, and I could be wrong, that these are just too general and we need them to be more specific.
Public awareness sounds more like it's a method of how do we solve some of these other
Yes.
problems.
Part of the next
A means to
process.
an end kind of thing.
Yes.
And I would agree with Frank, that's a good way to prevent some problems if we can get the awareness
If we
out
can
there.
educate people
Right.
at a younger age, or even those who are elderly, continue to educate them.
So, I mean, I think this pertains to just about any need. How do we get the word out, whatever the problem is, whether it's a mental health need or
Right.
And then
physical
you'll
health.
piggyback, this list is the what do you educate on?
Right.
You educate on, prevention of stroke and heart disease, but you're kind of giving the how and the
How
where.
to, yeah, how do we do it?
But like
Which is
Kelly said,
extremely
that's in
important.
the improvement.
Right, that's the
Right.
part of the
That's
next
how we-
process.
how we
that we're-
address
I don't know
these
about it,
issues.
I just,
Yeah, I know,
I'm taking
I know.
this, so
Right.
I.
No, I can tell you, Frank, that, things have changed, and you're absolutely right.
Yeah.
We haven't done that in the past, I'm just speaking for the health department, not the other agencies, but we haven't done a good job of that in the past, and we're trying to move that way. That's why we've expanded our health education department, and in the CHIP, it will address issues. When we choose an issue to target, we're also going to have that kind of education involved.
Including social media, we're talking to even kids and so forth, as a public awareness. If you're using Facebook, things like that.
Point of process, I'm hearing objections on one ground or another to three things on this list. The immunization need, which I think Kelly articulated some greater specificity than exists in the word immunization. That if it's okay with you, Kelly, we might come back to you for language there that would pin that down, and that can be reinserted as a perceived health need. We also had, I think, a very clear statement of the need for public education and greater awareness of public health issues. And we've got dialogue in the minutes to that effect. And that, there's also, I'll just point out, as a part of the outline for the report that was presented in broad terms in our very first meeting, there is language in there about capacities to move forward and address health needs. And what we can do is take the insights you just shared and make sure that they become a piece of the overall outline for the report, so that that concept is properly addressed. Because I heard no disagreement in this group about the underlying point that was just made with regard to the need for education and awareness. I think the issue had more to do with definitional categories that we're using in particular cases. And so I think we ought to have our records indicate those three objections took place to this list, and then we will take steps to fold those concepts in as we proceed. Does that make sense? Yep. Our way of process. Any other concerns relative to this list?
I have some issues in regards to the categorization, I guess, and it's just,
Which categorization are you talking about?
well, when I look at this, I look at things like, okay, early diagnosis and treatment of cancer, number 3, and then later we talk about
Which piece of
incidence
paper
of
are you
cancer.
looking at? Okay, I thought we were, can we just finish up with this piece of paper first before we move to the
Oh,
next?
yeah, we're done with that,
Okay.
unfortunately. We beat that
You've
stuff
moved on.
Okay.
I've moved on anyway.
Yeah. Very quickly, any other suggestions on this list of omissions?
You can always email me.
The intent here is not to remove issues, it is to remove noise. If there are real issues underlying this, we need to surface them and fold them in as we go. I think the discussion we've just had will allow that to happen on those two cases. Okay.
Frank, when you said public education, you meant public health education? So are those the same thing to you, public education and public awareness of public health? Public awareness of public health. Are those the same things? Okay, I'm I'm confused.
I think they're both. I'll do some to that. There's health classes and other things that the schools, some schools provide a lot more than
Okay.
other schools.
Okay.
And the same thing with the community idea of public health and where we can reach people that aren't necessarily in traditional settings like public education, like we've got homeschool kids.
So it's public education means health in school, I mean, teaching about health in schools? Is that what you, I'm trying to.
How I look at the two things, to me, are two different things.
Okay.
When you talk about public education, you might be getting that in the schools, but they're not getting that back to the community, to their parents, and, you know, those kids are getting some basics, but it's not moving anywhere.
Okay.
You know, and then you need to make the awareness to make sure that the parents or guardians, whoever, that they're aware of what's going on. We gotta get it from both sides. It's the education that the kids or whoever are getting, but here's back here, and these people aren't aware of it.
That's
So
fine.
to me, you gotta hit it from both ends. So there's awareness and there's education.
I do think we just basically stop it right there. So as soon as they walk out the school door, so
Well, I think,
it never goes any further.
I think there's two good examples. First of all, the 3 Rs, reuse, recycle, whatever the other one is.
Reduce.
Yeah, but the Ohio Department of Natural Resources began a very strong program to educate teachers, to educate the young kids. And now, a lot of times we hear from the kids telling their parents, well, let's recycle that, let's do that. The same thing happened with seatbelts. I remember one time my wife wasn't wearing her seatbelt, and it was our 10-year-old son who said, Mom, put your seatbelt on. And that happened through the public schools too. So I think it is a process that goes both ways. Public health education can come from us and through our education, but also I think we need to promote programs like that through the public school system.
Yeah, I guess I was just seeing them all as public schools as one avenue, but it's fine. We can.
And if I could just say one, and that's a great example. If we start and we're training our children, we're hope that if there's 100 kids, maybe 20 of them are taking it home and then do it to their parents. And maybe as they continue to grow and work through the educational process, they'll pick up on it more. So when they become parents, those things, so we're, you know, things that didn't happen with the elder group are now changing. It's just like the way life is now with cell phones and everything else, you know. My mom had the worst time, but my grandbabies taught me how to do the darn thing, you know, come on. So I'm just saying, it's just a process we need to work with. It's gotta be an education process starting somewhere in life, and there's gotta be awareness because we have people who aren't in that education process, but they need to be trained or, you know, get the information that they need.
Yeah. That's very good. It's well articulated too. And I think the point that we were just discussing is kind of the definition of education and awareness. And what I heard, if I've heard you correctly, is we're concerned about education and we're concerned about awareness. And our notes will take count of that fact and it can be incorporated as we go. Any other final discussion on this list? This was good dialogue. This is what we should be doing here. So I don't want to, how do I say, gloss over important dialogue, but we do need to keep moving here. Okay.
Just one other thing.
Yes, sir.
I'll issue your life citation for the seat.
They're always helpful.
Fair enough. Everybody has their purpose here, right? Fair enough. Okay. So what we will do is make notations on those 3 items, 2 of one variety and 1 will come back to Kelly for language on immunizations, okay? That will get added to our set. Kelly, you were going to go back to this piece of paper a moment ago.
Yeah.
And this is the groupings of the needs that Josh created. And I think the general intent here was to get beyond these narrow indicators to concepts of need that are more manageable. And Kelly, I understand you're having definitional issues here, so let's come to that.
Well, it's not really definitional issues, it's categorical issues, and I guess it's just, I feel like we're flipping back and forth a lot. So when I look at these, I put them in broader categories of chronic disease prevention, stroke, hypertension, diabetes. You know, can those type things fall underneath chronic disease prevention? And then we can talk about dental health, and then we can talk about cancer and early detection and maternal child health, so that when we're looking at this list, all of those things are categorized together instead of going back and forth. And I guess,
Do you want those all to be, you want prevention of chronic diseases to be the need?
Well, that's how I see it, but I don't want the group to, I want the group to
See,
all
I
talk about
would
that.
personally say that I don't think that that's narrow enough. That doesn't tell me how
No,
to.
just when I'm
plan an
looking, when we
intervention.
start looking at going through this box, instead of saying, okay, today, we're gonna start on number 3 and we're gonna talk about cancer, and then we're gonna go and we're talk about stroke, and then later we're gonna talk about cancer again, and then we're gonna go back and talk about diabetes, I just feel like we're flipping back and forth. If we could just take the numbers and put, you know, these fall under access to healthcare, these fall under behavioral and health and addiction problems, these fall under environmental health
They
problems.
are.
They-
They're still in
We'll
those.
be using this piece of paper, we'll be using a different cheat sheet that will be organized like that. This is organized by data supported and perceived, so there might be a little jumbled that way.
Do you remember when I first presented the indicators, there were kind of some, I just made them up,
Yeah,
overall topic
yeah,
areas.
right.
And
So-
the cancer thing was actually, in some parts, and we can change these groupings as well, some of it was me. In my mind, the mortality from cancer is very different from diagnosis or incidence of cancer. Mortality has to do with early diagnosis, screening issues, as well as treatment issues, where incidence.
How many, what is the?
Right.
So, when we presented the results of the data work group, the 73 indicators, are those in these 12?
Yes.
Yes, okay. So, of those 73 indicators, it narrowed it down to 12 health needs.
I think you think like I do, very data-minded, and I find this, for me, this is a little bit confusing
Yes,
because
it's confusing.
I don't know which indicators underneath the overall health need were ones that had data,
Yeah.
didn't have
Yeah,
data,
so that's
had good data, had bad data.
I
So,
think the main purpose of this simple list is to show the grouping. I think because we try to separate out the data supported from the perceived, that's what usually comes from. It's just a simple list of, this is how we collapse the indicators.
so just forget
Forget those categories.
for
Yeah.
now.
All right.
I will say, the next item on the agenda is this issue of perceived versus data-driven needs, Kelly. So that issue is not gonna be lost on us. Okay. As a grouping, anybody have particular concerns they wanna voice? What I think I might suggest on this is, given the dialogue, people wanna look at this and communicate with Josh on any concern you may have on these groupings subsequently. Is there a time frame, Josh, you'd like that to occur? In the next week or so? Say, why don't we say, today is the 24th, why don't we say by August 1st, the end of next week? Communicate with Josh on any concerns here. Essentially, what we're trying to do is come to some understanding that these indicators are related to one another and that needs may overlap indicators. Okay? Is that okay? All right. I think where Kelly was kind of nudging us is where we are about to go on the agenda. So, I've lost it. Fair enough. What I'd like to do now is return us to the framework, okay? There were a number of conversations that have developed over the last couple of weeks. I heard bits and pieces of some of them, but did have an opportunity to talk with a group of folks yesterday about some of the core concerns that people had with elements of our framework, which, you know, by the way, still says draft, right? So it's a work in progress in a sense. And one of those concerns that came through very clearly in our dialogue yesterday is the desire to prioritize our health needs that are either perceived or substantiated in some fashion, and how that might be done. And I think the underlying concern here, if I can seek to portray it, and I will ask those who share this concern to amplify if you don't think I've done a good enough job of outlining. But my perception is there should be some differentiation in this process of needs that separates big needs from not so big needs in some way, shape, or form. So that, to borrow Chip's phrasing earlier, there's a workable number to focus on. And I think there was a concern, given the nature of a process like this, with people coming from many different perspectives, to just throw one need after another and have large numbers of needs. And so there was, I think, an underlying sentiment that was expressed to me that we should come up with some way where this group can weigh in some fashion on what the greatest needs are, okay? So that was an issue of prioritization and how we might go about that process. I think relatedly, a cross-cutting concern is we've got a large number, we've got a handful of needs that are in this golden green box, right? And we have one, and those needs are ones in which there's data that the data work group has reviewed and found to be reasonably strong. And then there's about 12 or 13 of these needs, just so people know the numbers. There are also about 67 or 68 perceived needs for which there is either not a corresponding Healthy People 2020 goal, or there is not data to align with a 2020 goal. So how do we deal with,
or we decided that the data did not meet quality standards.
Or I stand amended, 3 conditions, not 2, because that is one of the, I won't go back to the flow chart, but that's one of the pieces in the flow chart. So there's a large body of need here for which there may be evidence laying around. I'm harking back to the conversation we had a few moments ago. And somehow we have to determine as a group whether there's evidence supporting those needs. And I think there was a sentiment among a number of people that we should do so in a way that allows us to prioritize, number one, and allows the expertise in this group to be applied to those needs. The discussion we had last time was about this big purple box for dealing with the 67 or 68. And that discussion focused on testimonials from within this group and the bringing to bear of evidence supporting those needs, even though that evidence may not meet the golden grail that was defined by the work group. That is probably a slippery slope type of process where it's hard to draw strict lines on what needs are substantiated and which ones are not. During a discussion yesterday, there were a subgroup of the people around this table who pointed out that there are alternative ways we can attack this that take advantage of some of the advantages of the approach in this box, which is bringing to bear evidence and testimony from the group here, but which may add to it a quantitative component that can allow everybody in this room to weigh in on those needs and how important they are in a way that can be expressed in clear quantitative forms. So I'm gonna, instead of letting go, I don't know, Heather, do you want to comment on what came out of the meeting last time in terms of describing that approach? Or?
If Heather doesn't want to, I'll try. Okay. Because Heather's been put on the spot.
So you want to take a crack at it?
I'll try, but please.
There were a number of people in the room.
Yeah. You know, one of the things that was striking me in this process was that we're all here because we really care about the needs of this community. And we all have our own special, you know, oh, I want to push for this. I think that the best wisdom we could do is for us in this perceived health needs is to bring forth any evidence that we have, knowing, you know, maybe some of the data is not going to be strictly national or whatever, but the best evidence we can bring forth and our testimony. At that point, then, in instead of just saying, oh, okay, Sue, that's good, we like that one, okay, put that in. Or, oh, we hate yours, no, see, I said mine was okay. But instead of that, we thought that once we get that down to the people that have put forward that effort, that we then take that and do some kind of survey after that presentation of information. And that people then on some kind of maybe a minor scale or something would be able to say, I think that was really, that is a real
That
received.
ranks very high.
Ranks high.
In priority for this community, or I don't think that ranks very
Right.
high.
And that way you're not just having, okay, well, everybody's gonna sit around going, yeah, that makes a good point. You really have to then consciously, as a member of the committee, think, that way. And I think that'll help in two ways. One is, it provides those of us who want to bring evidence forward to do that, we still do that. But it also helps us narrow down, I think, what Chip was saying, which is daunting when you come up with 108 or whatever we had, to bring it back down to, okay, there might be out of those 60 whatever.
67, I think it became 68 just a few minutes ago.
Yeah, there might be 25 that really
No,
matter.
that wasn't you.
That way, there's a more manageable number of indicators that we really are going after. That was the idea of the group, so if I represented that okay, everybody?
And I think the idea was that it's not invalidating
No.
needs, it's just saying that according to this group, this is a set of needs that this group feels are more of a priority, at least at this point in time.
Yeah, and to bank on that, to actually say that, one of the things that I said was because this group is being asked to be part of this, it seems like it's a more logical step. We really want to know what we think is happening, to come up with a way that we can put our vote in, quote unquote. Not that we're gonna do what your work is in the next phase, but that we can narrow it down so that we have some input into that. Because the way it sits right now, we substantiate needs and then, okay. So we're trying to quantify it and make sure that we all kind of really look at this as Chip said earlier, not just in the glasses of, like, as alcohol and drug person, but in the glasses of a community member. So that's really important.
Sue, I'm gonna interject what I heard yesterday. First off, I think this idea evolved in a series of discussions, but it took specific forms. I think the concept was, we got 67 or 68 needs now, if you accept a grouping concept. This group has a fair amount of expertise. Quite frankly, that expertise has been demonstrated in the last hour and a half of our discussion in some areas. The process envisioned in this box was a process that would draw up evidence that is known by the people in this group. And I think the idea that emerged yesterday was, let's build on that perceptual evidence and then add to it a mechanism to quantify. Forgive me for, I'm going to repeat a couple of pieces that Sue pointed out, but I think they came out rather clearly in the discussion yesterday. The idea that if we know the 67, 68 perceived needs, and there may even be a few more that dribble out before that, I expect there will be, and those evidence, we now have some information about those needs based on the work that has been done by Dr. Baird and the previous needs assessments. Those needs could be briefly described with the evidence supporting them in some digestible form for this group. This group could also devote a meeting, or maybe two, but I think the hope was one meeting, where the expertise of this group, in addition to the information that we have now at our fingertips, could be brought to bear in the form of a short update on this need and why it's a need. And then this group could become the target audience for a SurveyMonkey survey that essentially aligned these 67 or 68 or 69 or 70, I expect we'll probably bump over 70 by the time we're done here, needs, and essentially construct a 5 or a 7-point Likert scale that would be filled out by the people in this group essentially ranking those needs on a Likert scale to produce a quantitative itemization of this group's collective viewpoint.
Guess who recommended a quantification? Sorry, so.
Well, but-
I just would like to say though, I mean, that's a very, and I admitted this when I recommended it or proposed it. I have a very one-track mind, I admit it. So if you see flaws in that, or you have something that is more qualitative based, then there are other options.
Well, I'll just interject very quickly though, because you can characterize this as quantitative, but the evidence does not need to be completely quantitative. It could come in many different forms. The only thing that's quantitative here, at least that I heard, is how you count at the end, right?
The prioritization process.
That's exactly right.
Could you explain to the group, just in case they don't know, what a Likert scale is?
Oh, yeah, it can be constructed in multiple ways, but they're called Likert scales or feeling thermometers, or when you construct a survey question, you construct it on, to what degree do you agree with the following statement? A whole lot might be 7, and not at all might be 1. And we would construct a series of questions, essentially defined by the number of needs. And that survey would go out to this group and essentially produce a accumulation of this group's viewpoint on how important those needs are. And then those needs could be subcategorized based on those quantitative results for final presentation. This would allow a prioritization or a narrowing, much like what Sue and Chip have voiced, while at the same time leaving open the kinds of evidence that might be brought to bear on the process. And that evidence could come in the form of the information that is existing in the current needs assessments. It could come in the form of additional data that is provided by anybody in this group relevant to that need. And it might also come in the form of a brief presentation. I mean, all of you work in particular areas, quite frankly, are experts in different areas, and are well positioned to persuade your colleagues that there is a real need here. And by taking multiple sources of information, presenting them to an educated audience, and producing evidence of qualitative and quantitative varieties resulting in a quantitative measure of this group's cumulative opinion, may be a method that we can take the advantages of this purple box and introduce greater structure to it. That was the idea as I understood it yesterday. I'm going to step back and be quiet before
John, just one thing, brief was the big thing. I wasn't expecting people coming into a half-hour presentation. You know, a simple paragraph, some simple figures, data that you might have collected, and very brief, maybe 5 minutes on why you think it's important. You know, because all of us here could talk on our topics for hours, I'm sure. So.
Well, and one point that I think we need to keep in context as we're thinking about this prioritization process is when we're looking at these health needs, we're thinking about them from the standpoint of population-based health, not necessarily the individual level, because when we're thinking about going into the community health improvement process, what is it overall impacting the community? So we may know that there's 5 people that are impacted by this rare disease, and that's, you know, unfortunate and does impact the health of our community. How much does it impact the health of our community? So that when we're moving into the improvement process and we're looking at policy development and program interventions at that level, we're actually moving the barometer of the health of our community, not just the health of individuals. Does that make sense?
Yeah, I was thinking along the same lines, Kelly, where, I mean, 2 things come to mind. Talk about quantification based on like Likert scale. We get all our scores, but that's still subjective. But when I think of prioritizing, I always think of 2 things. One is it going to kill somebody? So there's a death factor in there. I mean, that to me always bumps it up a notch. And like you're saying, the total impact. So it doesn't kill somebody and there's only one person that's affected by it. It's like, I don't see that as a big thing. But this is killing a lot of people in the community, and it is affecting a lot of people. So I don't know if there's another way to throw in quantification of what we mean by priority, how we're thinking about it. So if we are filling out a scale, is there some criteria that we're using?
Well, that's a key point, and Dr. Hornbeek and I talked a little bit about it yesterday, is how would we pose the question? Would it be, you know, how important do you feel this health need is to the health of Portage County on a scale of 1 to 10? Or would it be something like, I mean, it could be posed 20 different ways. So,
I think you could put it keeping in mind in the directions, keeping in mind that these are the indicators that we're trying, and I think what Joel said was pretty good, which was, is this killing somebody, and or how is this affecting?
So how severe is it versus what is
Yeah.
the total impact?
Right, those two in
Yeah.
particular.
I just sort of think-
this is a category of perceived needs.
Right.
So that should be clarified as well. And, you know, that allows us to measure your perceptions.
But I think also, like, the data piece bring that as well, because if it, you know, it's my perceived need, this is important, then I better find out, get some data on that as well. But, yeah, this is
Yeah,
killing
and-
people, and it's affecting a lot, it's killing a lot of people.
And that's why we want to allow for the testimony, because I'm certainly no expert in mental health. And so I want to hear from you of, you know, why certain needs in the mental health area are very important to the health of this community before I go in and take this survey and rate what I think should be priorities.
I'm not sure.
Chip had a comment.
Yeah, death is an indicator, but I think quality of life may be even a bigger indicator. And I mean, things that affect the quality, health-wise, affect the quality of our lives may not kill us, but it's definitely detrimental to us. And I think in that respect, a lot of times, and most people around the room are not environmental health people. And we take environmental health, then you're talking about quality of life issues too, and that's part of this discussion too. That's not that death isn't important.
Destroys the quality of life.
Quality of life.
Yeah, that's right.
Dan, you have a comment?
Yeah, I'm hearing all this and it sounds absolutely fantastic, it really does. And I applaud everybody here for doing what they're doing. My question at this point is, when we get all this information, are we gonna compile this into a report, okay, or a publication? Okay, and if we do and when we do, I'm sure this will end soon, eventually, you know, it's got to, okay? Who are we gonna present this to and how are we gonna do it?
You want me to do that or you want to?
Well, let me, this is the community, we have to, for accreditation, do a number of things. Community health assessment, and community health assessment. So we will take, and then I believe almost every agency in this room will be able to use this now.
Sure.
But the health department is the one that is going to be charged with following up on this, because.
Making sure everybody gets
Right,
this information.
but what we take this is, we take this information, and then we develop the CHIP, the Community Health Improvement Plan. So we may take some of these issues, and our improvement plan is going to tell us how we're going to address those issues. The good thing about this and this group here, and the work that we're doing, is we can't ignore it. We can't say, oh, that's a nice community health assessment, put it on the shelf this time and walk away from it.
That was my
Yeah,
intent.
we can't, at least, maybe some of the agencies here can, because they're going through accreditation.
It just seems to me
But we
like
won't have a
there's a heck
choice.
of a lot of input, there's a heck of a lot of time being spent on this. I just didn't want it to end up like that on a shelf somewhere where, you know, it was all for nothing.
If we get through this initial process and get accredited, the next time we have to do this on a regular basis to go through accreditation again, they're gonna look and see how we address these plans. And if we don't address these plans, we won't get accredited again and have to go through this again. So this is a process that we'll pay attention to and we'll act on. Not all of it, you know, we can't do that, but we will pick and choose what we can, and we will encourage some of the other agencies to do that too.
I'll just interject briefly that the health departments are on the hook in one sense with this process. But it would be my hope, and I think it was the discussion in our very first meeting, that every organization around this table over the long haul holds the potential to benefit from this kind of shared focus. Because every organization represented around this table has resources and capabilities that can benefit the efforts of the other organizations involved. And so my hope is it's not just the health departments.
No, and I would not think it would.
Well, and I think everyone in here becomes a champion of the process and continues to carry the torch through the community improvement process. And we also talked, Dan, about public engagement. We can't just do this in the silo of the stakeholders and those who are providing programs. We have to engage the public in the process, so they're part of saying, you guys are crazy, that's not a health need, you know?
Well, I would certainly hope that once we get this done, and we have this document, that it would obviously, hopefully be distributed in a township association meeting, let's just say for one thing, where they could spread it to each one of those communities. I mean, that's a quick fix to get it out there, I mean, real fast.
And I know it'll be on our website, so
Okay.
anybody that wants to go to.
There again, yes, that's another media, way of getting it out, yeah.
Point, I'm sorry.
No, I'm
Just point of process, I looked at the clock and it led me to want to kind of interject here. We've got about 10 minutes till we're scheduled to leave, 11. And I think we've thrown out an idea that emerged from discussions that have taken place informally. What I've heard around this table so far is I've heard an undercurrent of interest in evidence. I've heard an undercurrent of what I would call support around the idea that prioritization has value and quantification here may have value as long as it's an evidence-informed process. I did hear one question, concern, which I'm not too surprised at. It has to do with how do you craft the instrument around which that survey would be constructed. And so let me just stop here. If there were agreement on the instrument, does a process whereby evidence in support of this list of needs and a survey process within this group make sense to people? Is there anybody who feels that that does not make sense to move forward with? Does that make sense to you, Dr. Sandy? Any comment or concern? If there's concern, please voice it.
It's not really concern, but I thought I was hearing maybe from Sue that there would be in conjunction with some additional data. So I don't know how you really make that process work, but.
Sandy, maybe I should mention, I guess what I was thinking is, let's say I'm gonna come and talk about alcohol, and we don't have really great data necessarily in the county. We have some, but we don't have. But I may be able to bring some evidence, like over the last 3 years, we've seen 27 deaths, people that have been in treatment. I've seen I could probably bring some agency data to bear, and that would be more localized, and I think is a valid piece. That's kind of what I'm talking about. I agree with you on the bigger picture ones, like Medicaid and all. I'm really talking about focusing in on this community and its need.
Oh, I understood that.
Okay.
And I think that we have, that many of us here have that powerful data. And, maybe it's just an opportunity to skew the group think, but I think it's relevant.
Well, and I think the idea behind this box is to allow that opportunity to occur. And so the question is, how does that occur? The discussion that came out yesterday, I think Sue voiced in her comments today, was, well, maybe we devote a meeting to the presentation of that information. And that can affect people's thinking regarding how they would fill out the survey instrument. There may also be information that we could compile from the previous needs assessments, as well as the compilation of information that Dr. Baird has constructed. And we could create, in essence, a little paragraph with that information for each need, and then have an opportunity for essentially kind of make your pitch on the needs as best we can as a group, and let that inform the overall completion of the survey. The survey then becomes a means to talk about those results in a structured way that may in fact narrow the dialogue in the way that I think both Sue and Chip were talking about. And I guess what I'm trying to understand here is whether that kind of broad approach is one that makes sense to folks. And I'm seeing some nods. I've not heard any. I've heard issue about how we construct the question, which I think we may need to spend a little more time on, and concern about evidence, which I think we do have an approach to deal with.
One last thing, somebody might not be able to make a meeting, but they're gonna receive the survey. So my suggestion was they do what they did the first time, which was to videotape any of the presentations, so that people can go and review those. And that way they can also make, an educated guess based on what they received.
What about the people that aren't here?
That's what I just said.
No, not meaning part of this group. I'm talking about, like, if we think homelessness and poverty are a perceived need, but the people from Freedom House or the shelters aren't necessarily part of our stakeholder group, can we reach out to them and say, can you come and talk about this perceived need? Because they weren't necessarily invited to the table.
Well, they were, the ones you talked about. Carol Beatty was here, who would be the shelter and homeless.
But she was just from the Wyndham,
No, Carol's.
oh, from Family Community Services, okay.
And I think the group was pretty representative. I guess my big thing is if you're bringing in other people, not because I don't want more people, but because they haven't been part of the process, you may end up with, an hour presentation.
No, I know, but if we have most of our needs being presented by social service agencies or mental health agencies, we're also going to skew our list of needs based on what data is being presented. So, for instance, if we talk about environmental health needs and we're talking about asthma incidents or lung problems, but we have nobody here that's gonna talk about what our air quality is, I mean.
But I was guessing, this is my guess, the first group, and again, you guys have Chip and I don't know what the other one is that we're part of right now. But once we get our part narrowed down, then I think it's on the health commissioners and that secondary group to take that thing. I mean, I don't really think we're gonna leave out, I guess I don't believe that we're gonna leave out anything, Kelly.
All right.
I do hear you, I just don't think we can invite every aspect of.
What about if we would do a roadshow, when we get the final, what we think is the final draft developed, then we make sure the paper knows that we have maybe Ravenna High School or Med People or something, have a session to review the document in a public meeting.
Yeah, I wasn't so much thinking about that, I was thinking about this purple box, and as we're doing these presentations of the testimonies for the evidence, and if we get to one of these on here that is talking about maybe the environment and air quality, and we have nobody in here that can provide, I mean, I guess can the health department bring that as part of the Akron air quality, that whatever data they have,
I wouldn't see anything to prohibit that.
Yeah, so,
Someone from here submitted that, didn't they?
right, so, but the Akron air quality group isn't here, but yet I know they provide a report.
But there's a reason why somebody who submitted it and thinks that it is a priority
I think
health.
that came from one of the
The focus
assessments and
groups,
has
yeah.
data behind it. The data wasn't good enough to make the list of 12, but the data's still there as evidence. So Karen, do you have a report?
Personally, if I were gonna streamline a survey and like there's an audience member and take it, if I were unable to come to these meetings or able, it would be nice to save the question of the indicator, pick whatever one, and then underneath it, 2 sentences, max 3, that's just stating the purpose, the cost. So that's kind of your 5-minute presentation in a boiled down nutshell, and then the rating. And just like the tiniest paragraph under each one, so that you have a little reference point. I'm gonna walk away and be like, oh, that was 2 weeks ago, those presentations. It's all kind of a jumbled mess. I don't remember what was compelling, or I remember something that was particularly compelling, but maybe not remember everything. So it'd be nice to have just the boiled down piece under each one, so you have a tiny little 2-3 sentence piece to read. That means that you could reach out to agencies that can't be here and ask them by email, can you please just send 2-3 sentences
Right.
if you'd like to participate.
And this will be, I think the way to make these decisions a little less daunting is to recognize the reality that this is gonna, if the FAB accreditation process continues to drive this kind of effort toward update, there will be updates and updates going on into the future on this kind of thing. I don't know, let me stop, because we really have just 3 minutes left. And I'm trying to figure out if we're deciding something here or not, essentially.
One thing that was, one thing that wasn't brought up, and I think you should consider it, is your time commitment in taking a survey. That has 67 needs on it with 3 sentences each, so.
Well, I don't think the survey would need to have the 3 sentences, the study guide.
That is what I was suggesting, just for a reference point, but it doesn't have to happen.
You could have the
Document.
document to the side would be.
It's the same thing to me. It's just an ease to just copy and paste it into a survey monkey, so you don't have to be switching.
But
back.
still, I mean, even answering and really thinking about 67 needs too, I just want people to be aware of that.
Yeah, that, if we do go that route, the request would be that everybody in this room and those who are part of this group who are not here would take the time to fill out the survey.
But if you had a comment box after each question, I mean, the chances, 98% of the people aren't even gonna comment. So, I mean, I don't think it's gonna burden the survey that much. Those that wanna comment will have an opportunity.
Let me just ask the question, how many people are people comfortable with this kind of approach? If you've got concerns, we can explore other approaches as well. I'm gonna just go around, Dan, you feel?
So, what are we saying, comfortable with each of us rating? What do you guys?
Good point. I thought I was clear in my head, but I wasn't clear in my voice, so thank you. Comfortable with the concept that there might be a process that applies evidence in some standardized form, and then a set of questions in a survey that would go out to this group to enable a quantification of the persuasiveness of that evidence cumulatively across the group. Was I clear enough in my response, Joel?
Yeah, there's the evidence, but there's also trying to get prioritized.
Yeah, there's two, I hear 2 questions.
Yeah, I do too.
Okay.
Maybe we should do it twice.
Let's separate the questions.
Yeah. Are you comfortable with the way we're gonna get the evidence, which is testimonials and however the 5-minute elevator pitch? I mean, I think, and then the second question is, are you comfortable with the survey prioritizing?
Are those the 2 questions you're hearing, Joel? Is that accurate?
Right, and I have 2 separate answers.
Yes and no?
Yeah, well, I'm not sure I want to listen to 5-minute presentations on everybody. I'd rather somebody submit things and they're written up like Karen suggested.
Yeah.
I'm not going to sit through it, I'll be honest. Yes, I will fill out the survey, yes, absolutely. So question number 2, yes, I will do that.
So, a meeting.
So I have stuff on here I would like to take off, for the 68. Because they're mine anyway, I don't like them now anyhow, so. So I can eliminate some right away. So in some ways, it's almost like, there's too much stuff here, there's a lot of it redundancy.
Well, and I guess that's where I'm at too. I would like to see that this be condensed down, but I don't know how necessarily to do that, but I don't necessarily want to spend a survey of 73 indicators and sit it through presentations
I
on
don't
that.
think every indicator will have a presentation.
Well, but these aren't indicators, I'm sorry, these are needs.
Okay,
So that-
I don't think every need will have a presentation.
Well, but how do we decide which ones?
I think that any of the needs that fall off of that, at that point, there's not as big an interest in it.
So-
If you have a passion about something, you're gonna comment.
We're not, we've not gone through this process. I mean, really, you have to do number one first. Are there testimonies from the partnership of 2 or more people that think that this is a need? That's the first step, and then that might dwindle this down to 30. And then, from that 30, there might be testimony that you would get supporting evidence.
So you're suggesting, I'm actually seeing a suggestion in your comment here, Kelly, that one next step here might be, in this response to Joel Mowry's comment, that we could reach out to the people in this group and say, given this list of needs, which of these do you have evidence you'd like to bring to bear on the process? See what kind of response we get to that, rebuild this list based on that, and then come back to this question.
Well, I think she was also saying the other point of 2 or more people, so it's back to those 2 questions. You have the evidence, and of this group, how many want to support this one? Because we'll be able to eliminate some that way.
Exactly, I think that could be a vote where everybody's, okay, let's start going through them. Who in the room thinks that this is important and knows that they may be able to bring supporting evidence? 2 hands go up, okay, it stays on the list. You know, I mean, I'm just trying to figure out a process of how you start to pare it down more.
I think we have to do this probably via email, just because people aren't here,
Right.
and
What happens to the
whoever
stuff
shows
that
up.
is not on the list?
I'm sorry?
What happens to the stuff we take off the list?
It goes to that other box on the process over here.
Okay.
It wasn't perceived as a need because it didn't meet that criteria in the purple box, right? There wasn't two testimonies, so it's not substantiated. I mean, I'm just trying to follow the flow chart. Am I not correct in that?
Well, I'm not sure I understand your question, Kelly. Can you repeat it?
He
I
asked
also
what
wanna be
happens to the
sensitive
stuff that
time.
doesn't stay on the, if we go through and ask yes or no, two or more people think it's important and needs to go through the testimony process. He says, what happens to those things that fall off? And I said, well, if I'm following this process down, it doesn't stay on because it didn't meet these two criteria, so therefore it then becomes a not substantiated need.
And we prioritize what's left.
Right, and then you prioritize what goes into the purple boxes, right? Am I simplifying it?
No,
You guys are all looking at me like I'm crazy.
No, I think you've just described the process. What I'm trying to understand is, are you thinking that there's a problem with that?
No, I think he was asking a question, I was just trying to answer it how I understood it.
Point of clarification.
I see.
Yes.
Okay. So what I'm hearing here, and I know people have to leave because we are at the 6 o'clock hour, actually a couple of minutes after, is that we probably need to reach out and see if we can winnow our needs list a little bit further. Is that sound correct? Is that what I'm hearing? And so why don't we make an electronic effort to do that? We do have, I think we will have to, the other thing I'm gonna suggest, because we're running out of time, we will have to do some adjustment on our timetable. Right now, we are scheduled as a group to meet again on August 28th. And that is the next meeting that is currently scheduled. So I think what we would do is try to get a winnowing process occurring prior to that time. Does that make sense to you, Josh? And then come back on the 28th and iron out remaining details on this approach. That, I'm looking over, I see.
August 28th, right?
And what that means is we will adjust our timeline as well to reflect this. But I am hearing that people believe the survey approach is okay and are willing to do this.
Can I ask one question?
Yes.
Because of Joel, does that mean we're not gonna do anybody talking about the topic, no testimony?
Oh, I didn't hear people say we shouldn't have testimonials at all. It's a question of when would be my.
Yeah, okay, so I'm just making sure, because that's not. what
Am I interpreting your all? I mean, I didn't hear anybody concerned about, I heard Joel say he may look at it differently, but I don't think that's a problem, quite frankly. There could be a meeting that would be devoted to this, and people could go by the written information, and that's a self-select situation.
John, how difficult would it be to send out an email that lists those items and say, do you support yes, no? And then you just go through the list and find out, we got 2 people here, now that takes it to the testimonial phase. I mean, that seems to me it would be real simple to send it out and get everybody involved.
I think my instinct is that could work. So if we have 2, then what that would allow us to do is move to the testimonial phase on the 28th.
That's what I was
Yes.
concerned about.
Is that,
See
Sandy,
how
you're
many
smiling,
are
is that good or bad?
Yeah, I think it's a yes, no question.
Yes.
Yes, no, don't make it anything.
Yeah,
Yeah.
it's a table.
So it's one piece of paper with 2 answers, yes, no.
That's it.
And then we use that as a basis to invite testimony on the 28th.
Yes, yes,
Yeah.
great.
Thank
Good
you.
process.
Thank you, thank you. For your clear answer too. Okay, thanks, Dan, for coming. Okay, what we will do is we will have a follow-up with exactly what Commissioner Porter pointed out, a yes, no. We will then have an internal dialogue to try to schedule people for the 28th. If something comes up in that process, we will be in communication with you by email regarding adjustments. I think we will also make some adjustments in the timetable as we proceed here too, because we did pass out a timetable that we are now altering by this meeting today. Any final comments or concerns? I see, Chip, any comment you have here at the
No,
point? I see Karen looking very contemplative.
I'm just, sympathizing with Josh and Nish, kind of like, are you doing some master tally list for every one of these?
That's his problem.
I wouldn't
No,
do
it's
that.
Oh, man.
Here, it's an Excel spreadsheet with a yes and no column, and you add them up at the end.
Yeah, no, that's
No,
what I'm
talking
thinking
about
too,
you
Kelly.
giving it out to everybody.
Thank you, everybody, for your good
If you
dialogue
don't get them all
here.
back, you don't get
This
them
is
all
a
back.